Rosacea is one of the most common dermatologic diagnoses that we encounter. However, over the past 20 plus years, it's undergone a significant shift in diagnosis, classification, and management. From the 2002 National Rosacea Society subtype driven classification to the more contemporary phenotype driven framework. The key idea was simple but powerful. Rosacea management improved when we stopped forcing patients into subtype labels and focused on the actual features, that is, their presentation and phenotypes, their patient burden, and the treatment targets. The core thesis. Let me summarize for you the central concept. For many years, rosacea care revolved around the following domains: diagnosis, assessment, treatment. And in the subtype era, those domains were tightly linked, and the subtype label determined the categorization, their severity grading, and how treatment was selected. But the phenotype model decoupled those processes, and now we diagnose rosacea based on individual features and treat those features that matter the most to the patient. The arc of change. The evolution happened gradually. In 2002, the National Rosacea Society introduced the first standardized classification. In 2004, severity grading was added. And for more than a decade, clinical trials and systematic reviews were structured around this framework. But by 2017, the limitations were becoming more obvious, and the Roscoe Consensus Panel proposed a phenotype approach that was then also endorsed by the National Rosacea Society subsequently. And that's where diagnostic and major phenotypes were formally defined in 2017 2018. By 2021, clinical guidelines, including the British Association of Dermatology recommendations, had translated this model into practical workflows. Here's the clinical pearl. The shift to phenotypes did not change the disease, it simply changed the way we think about rosacea, which in turn improved treatment decisions. The subtype era. The original classification solved an important problem. Before 2002, rosacea lacked standardized terminology. The subtype system created a common language for clinicians and researchers. The four classic subtypes were erythematotelangiectatic, papulopustular, phymatous, ocular, and one variant, granulomatous. Primary features included flushing, persistent erythema, papules or pustules, and telangiectasies. Secondary features included burning, edema, plaques, and ocular symptoms. And this system helped structure clinical trials and increased awareness of rosacea as a distinct clinical disease entity. Here's the clinical pearl. The subtype model worked conceptually well for categorization of common presentations, but it led to confusion by conflation. Why the subtype model broke down. Over time, several problems became clear with the NRS 2002 diagnostic and classification system. First, some primary features were not particularly specific. For example, flushing overlaps with menopause, blushing, and endocrine conditions. Papules and pustules overlap with acne and folliculitis. Telangiectasies are extremely common in adults who do not have rosacea. Secondly, phyma, one of the most distinctive manifestations of rosacea, was categorized not as a primary, but as a secondary feature. Third, subtype overlap was built into the system. For example, persistent erythema appeared in both erythematotelangiectatic and papulopustular rosacea. And finally, clinical trials became confusing. For example, a therapy targeting inflammatory lesions could look ineffective if erythema within the same subtype did not improve. Why? Because with papulopustular grading scales, you would have to conflate and combine both inflammatory lesions along with background erythema. So the clinical pearl is the following. The subtype model mixed diagnosis, severity, and pathophysiology into a single label, and that inevitably created confusion. The phenotype pivot. The phenotype model simplified diagnosis. Two findings alone can each establish the diagnosis of rosacea: fixed centrofacial erythema in a typical pattern or phymatous changes. If neither is present, rosacea can still be diagnosed when two major features are present, such as flushing, papules, and pustules in the absence of comedones, telangiectasias, or ocular disease. Secondary features support the diagnosis but are not diagnostic on their own. Instead of asking, which subtype is this? Ask, which phenotypes are present and which one drives the patient's disease burden? In fact, ask the patient to declare this to you. And that single change improves therapeutic precision. The evolution of rosacea features assessment. Assessment evolved in parallel. In the subtype era, we graded severity using a 0 to 3 scale for major features and then applied a global subtype score. Today, assessment is more targeted. Erythema can be measured with clinician and patient erythema scales. Papules and pustules are evaluated using lesion counts or investigator global assessment. And flushing can be evaluated with symptom scales. Patient-reported outcomes are increasingly being recognized as critical clinical trial endpoints. Importantly, if you measure everything, you measure nothing. Pick one objective endpoint per dominant phenotype. Let's turn now to evidence for treatment of the different features, starting with persistent erythema. When we look at treatment evidence, several patterns emerge. For persistent erythema, the strongest randomized trial data involve topical vasoconstrictors, including brimonidine and oxymetazoline. Both act through vasoconstriction and produce visible blanching within about 30 minutes. However, they do not alter the underlying disease biology. They treat the vascular expression of rosacea, not the inflammatory drivers. Inflammatory lesions. The strongest evidence in rosacea relates to papules and pustules. Topical medications like ivermectin, azelaic acid have high certainty evidence. Systemic agents like oral doxycycline and low-dose oral isotretinoin also have strong support for more severe or resistant conditions. Metronidazole remains widely used but has somewhat weaker evidence. For ocular rosacea, omega-3 fatty acids show moderate evidence for improving tear function. Of interest is that phymatous rosacea still lacks randomized controlled trials, and most recommendations for the latter are based on procedural experience rather than controlled trial evidence. A clinical pro is that most evidence-based targets in rosacea are inflammatory lesions, persistent erythema, and the least studied domains are flushing, ocular endpoints, and phymatous disease. So, how do we apply the phenotype guided workflow in practice? Number one, start by identifying the phenotype mix in that individual patient. Is erythema dominant, or inflammatory lesions, or telangiectasias, or ocular disease, or do they have skin sensitivity? Identify each of these and then initiate universal measures such as trigger avoidance, gentle skin care, photoprotection, and then psychological burden screening. Finally, match therapy to the dominant phenotype and ask patients for what of these different features they're presenting with bothers them the most, because that's where you can focus on a patient-centered strategy. The therapy can be inflammatory lesions, which we know respond well to topical ivermectin, metronidazole, or azelaic acid, and then systemic options like the oral tetracyclines and low-dose oral isotretinoin for more severe or resistant cases. Persistent erythema may respond well to brimonidine or oxymetazoline. Procedural treatments such as PDL or IPL can also address these vascular components. Combination therapy is often necessary because rosacea features rarely occur in isolation. The phenotype model naturally leads to combination therapy, which mirrors the biology of this disease and the way it presents in our patients. Let me close with a few key points. The modern rosacea consultation focuses on phenotype features rather than subtype labels. We should document the diagnostic phenotypes, the major phenotypes, secondary symptoms, their skin phototype, and patient burden. Treatment should then target specific phenotypes with measurable endpoints that are an increased burden for that particular patient. And as we know, evidence is stronger for inflammatory lesions and erythema control, but we still need better research for flushing, ocular disease, and phymatous features. Rosacea is not one disease, it's a syndrome of overlapping vascular and inflammatory phenotypes. And recognizing that complexity is what allows precision treatment and better research moving forward.